Alaina Hammond, rehabilitation psychologist
Can you hear it?
Yes.
Okay, good.
at Hospital for Special Care. And I'll be starting off our discussion today on COVID. Is it related to brain injury? And from the ICU to rehabilitation, our experience here at Hospital for Special Care. Dr. Timothy Belliveau, board certified neuropsychologist, will later discuss brain injury and COVID. And Wendy D'Angelo, Vice President of Development and Communications, will discuss some of the implications of the data and how we at HSC are addressing the social determinants of health, as well as health disparities in Connecticut. So today's talk will cover clinical data that we obtained from a small number of patients here, status post-COVID, during their rehabilitation, as well as research discussing coping with the longer-term effects of critical illness and medical conditions. There will also be an overview of COVID-19, as well as a discussion of on the questions of brain injury due to COVID. And finally, we will be covering the social determinants of health and disparities in health outcomes. So we will discuss more of this later, but right now I will be presenting on some of the data from 41 patients status post-COVID. Now we know a lot about COVID, much more than we did at the time when this data was captured. So COVID often manifests as an upper respiratory infection and flu-like symptoms. It can cause multi-organ disease, including the brain, and some require hospital level of care. COVID-19 and brain function, there's a variety of symptoms, and it can impact mental status and also lead to longer-term cognitive problems. Again, we'll get into that a little bit later, but I'd like to discuss right now the actual individuals and their data and their experience here at Hospital for Special Care, status post-COVID, and their journey to recovery. So the data that I'll be referring to was captured during April 9th, 2020 to August 6th, 2020. And there are a couple of caveats. This is a retrospective study. The data was originally captured to determine the clinical standard of care, given that back in April 2020, we really didn't know that much about COVID, like more that we know now, at least. So this data was really born out of necessity for care and not designed for research purposes, which means that there are a number of limitations when we interpret a retrospective study, and we will cover those. But first, let's talk about the demographics of the COVID unit individuals who were there. And you can see that there was a total of 41 individuals, and that right here. And then actually we had more individuals who were less than 65 years old. In fact, we had about 70% who were less than 65. Our youngest was 32 years of age, and our oldest was 90. Regarding race and ethnicity, you can see that among the 41 individuals in this cohort, there are disproportionately more individuals who identified as non-white, Hispanic, Latinx, or Black. This is somewhat similar to the overall pattern seen at the state level. And here, this is data from the state, the Connecticut Department of Health, which occurred around the same time period. So here, this is around 8/13/2020. And this is a limitation to a retrospective study. We unfortunately were limited technologically to only 4 categories for race and ethnicity. So white, Black, Hispanic, Latinx, and other, compared to the state of Connecticut, which has 8 actually. And going forward, we're working to address this to better and more accurately capture individuals of racial ethnic background and their identity. But you can see that they're relatively similar with respect to the state's data and our current population. Now, so for the purposes of this presentation, we'll be using the 4 categories when discussing race and ethnicity. And here you can see that individuals who identified as Hispanic or Latinx were significantly younger in age compared to those who identified as Black, white, or other. So more specifically, you can look and see the median here for individuals who identified as the Hispanic or Latinx was age 49 compared to 65, 61, or 58. And so additional demographic data includes insurance type, which really serves as a proxy measure for potential socioeconomic limitations as well as potential medical comorbidities. And there are an inherent number of limitations with that, but as you can see, there is a disproportionate frequency of Medicaid insurance among patients of minority, racial, and ethnic background compared to those who identified as white. Now, regarding mechanical ventilation, here you can see that about 82% required mechanical ventilation in the ICU. And that's right here, which is a significant number. And it gets interesting because when you look at mechanical ventilation with respect to age, it was actually our younger individuals that were more likely to have required mechanical ventilation than our older individuals. So here you can see the mean age of 57 versus no ventilation, mechanical ventilation, which is age 71. And this is statistically significant at 0.005. And the average days spent on mechanical ventilation. So the median here is 14 days, so about 2 weeks. The longest was 59 days, and the minimum was 2. So a large variation. So here you can see how individuals with Medicaid had a longer period of time on mechanical ventilation, 28 days versus 11 or 10. And this really speaks to the potential comorbidities and complexity of illness for individuals who receive Medicaid. And so here you can see for number of days versus Medicare and commercial insurance. And this was significant, again, 0.004. Now, the average length of stay versus acute care and our hospital here at HSC was pretty similar. So the median was 31 at acute care versus 23 here. However, if you look at the minimum and maximum, there's a large range. So at acute care, the minimum stay was 4 days and the maximum was 71. And then the minimum stay here at HSC was 8 days, but a maximum of 105. So really quite a large range. So next, let's take a look at some of the comorbidities and medical conditions. Specifically, we looked at BMI, diabetes, hypertension, and asthma as risk factors for COVID severity. And then we combined age, BMI over 39, diabetes, and hypertension to create what we call the metabolic risk factor index. But just a little bit about these risk factors. BMI can be split up into 2 separate categories. So over 29 is thought by the CDC to be considered a possible risk factor, but over 39 is definitely considered a risk factor. Diabetes, there are ethnic and racial differences, which I'll get into in a minute. And for hypertension, we really didn't discover very much. There was a trend to have more hypertension as we age, which is not surprising as our arteries get harder as we get a little older. And asthma, we really didn't see any differences. So let's take a look at BMI. So regarding BMI, women were more likely to have a BMI over 29 than men in this cohort, with a median of BMI of 33.5 for women versus 27 for men. And this was statistically significant at 0.005. Regarding race and ethnicity, and diabetes, you can see that among the 41 individuals in this cohort, there are disproportionately more individuals with diabetes who identified as Black or Latinx compared to white. This is unfortunately considered consistent with the diabetes literature and research at this time. So here is our metabolic risk index, which suggests that individuals who identify as Hispanic or Latinx and are Black met criteria for more than one metabolic risk factor at a higher rate than those who identified as white in this cohort. Now that we've covered the demographics, let's take a look at how did individuals recover. And the good news is that patients showed functional gains across all ages, race, and ethnicity. So that's an important take-home message, that everybody showed improvement, despite their age, despite their race or ethnicity or gender. And so here you can take a look at a way of looking at change using the FIM, which is a common measure of functional change in rehabilitation facilities. And there are 7 levels, and it goes off of the need of assistance. So at the bottom, there's total assistance versus the top, which is complete independence. And so here you can see some of the areas where people made improvement by 1 level. So their ability to eat, engage in oral hygiene, walk 150 feet, and rolling left to right, all showed 1 level of improvement on the FIM at discharge. And then 2 levels of change were areas such as lying to sitting, sitting to standing, walking 50 feet with 2 turns, a toilet transfer, and walking 10 feet. These all showed statistically significant improvements from admission to discharge. And then here, greater than 2.5 levels of change, you can see in individuals' ability to complete toileting hygiene, sitting to lying, washing their upper body, and transferring from a chair to a bed. And again, there were no subgroup differences in functional gains based on age, race, or ethnicity. So as a psychologist, like I said, this was really born out of necessity for an evaluation of cognitive and emotional adjustment. And what we did is we looked at attention, memory, and what we thought might be executive functioning, as well as their emotional adjustment. So we ended up having to evaluate patients remotely using an iPad via the telehealth, which has a number of limitations. But we came up with this battery of tests, again, for clinical purposes and not research. And looking back, there are a number of limitations. Specifically, when we chose to use the CAWET and the oral trails making test B, really what ended up happening is that these are oral tests where people are asked to say a number of items when given a certain letter. And what ended up happening is that respiratory functioning was really getting in the way. So unfortunately, these measures didn't turn out the way we had hoped. But we'll take a look at these 2, as well as the emotional adjustment using PROMISE measures, which is an NIH-funded open source measure. So regarding digit span, which is the measure of attention, you can see that most people scored. We had a valid number of 26 individuals who are able to complete the assessment. And most of these assessments occurred about 5 to 6 days after admission here to hospital for special care. And their mean was in the low average and the median was an average. And unfortunately, it was not correlated at all with the metabolic risk factors that we thought might have a role in their presentation. Here, regarding immediate and delayed recall, we used a test called the HBLT, and we looked at total recall as well as delayed recall. And ultimately, these were just kind of fell right below average, and they were not correlated again with the metabolic risk factors. So here you have T-scores of 32, 30, really in that below average range. Now, with respect to the PROMIS measures, this is interesting in the sense that we looked at pain intensity, sleep disturbance, fatigue, anger, anxiety, and depression. And what people reported all fell within normal limits, which is pretty amazing and really speaks to the resiliency of individuals after a traumatic experience. That despite having gone through heavy sedation, coughing, all sorts of procedures, most people were reporting adequate adjustment, and there really wasn't extreme distress that I thought might have been reported. What we did see, though, is that older individuals did tend to report a higher level of pain, so a higher level in pain intensity and more anxiety. That said, although they ended up reporting more of it, clinically, it would not have been outside this threshold. So that's important to realize. It was still within normal limits, despite being more than somebody less than 65 years of age. And then metabolic risk factors. We did see the only thing that correlated with the metabolic risk index that we were looking at was this level of pain. The more risk factors one identified as, the higher level of pain also people reported. And so that was the one correlation we did see. And that lastly, individuals who were not on the vent tended to report more fatigue. Now, this makes sense. They had to work extra hard. They didn't have that mechanical ventilation to help them breathe. And so the other thing, though, to keep in mind is that those who were not on the vent were also statistically older. So there is a confounding factor in that. And then lastly, there was a change from outpatient or inpatient scores to outpatient. So here you can see that I followed up with as many people as I could after discharge to home to make sure that their adjustment was adequate. And individuals who identified as Black and or Latinx reported more ongoing fatigue and anxiety versus those who identified as white. Those who identified as white actually reported greater improvements in these areas. And so I think that's really important to note that, you know, while everybody was here, they made substantial improvement without inequality, but then when they got home, their environment did play a factor as far as adjustment.
Hi, so we're going to transition now into talking more directly about the relationship between COVID-19 and brain functioning. And we'll be talking about our experience here at Hospital for Special Care with our COVID recovery unit, as well as what the scientific studies have shown to this point about the relationship between COVID-19 and cognitive functioning. So just to frame this more broadly, really, it brings up the question, can COVID-19 cause brain injury? And if so, how? And what do the scientific research tell us about some possible mechanisms that may mediate the relationship between COVID-19 and people's cognitive status? So as a way of introducing this, I want to revisit some of the cognitive data that Dr. Hammond had summarized before. from our experience earlier in the pandemic with a relatively small cohort of people who were here on our COVID recovery unit. And in our attempt to better understand their experience and their symptoms during long-term acute care, we were able to do some brief cognitive assessment despite the restrictions associated with being able to have close access to patients at that time. So I'm just going to focus on two measures. One is a measure of attentional functioning, and the other is a memory test that involves learning a list of words. And so as Dr. Hammond had referred to earlier, if we look at the group, their score on an attention measure called digit span was at the 25th percentile. So that's essentially below the range that we would expect for most people in terms of their ability to pay attention and concentrate. And then on a memory test that involved remembering a list of words and then checking that out again about 20 or 30 minutes later, as a group, they had a lot of difficulty with that, really at the 3rd percentile compared to what we would expect given that person's adjusted for age of each person. So when we were hearing at that time about the cognitive difficulties that some patients were experiencing during their intensive care unit treatment for COVID, as well as in the early phase of their recovery, what it brought to mind for us was two things. Our previous experience working with people in long-term acute care who are coming to our hospital from an intensive care unit, and the types of cognitive problems that would be common in that early phase of rehabilitation. And we also looked to the research on temporary confusional states or delirium. So that's what I'll talk about next. So here's a series of points about delirium or confusional state. And this is information is taken from the Psychiatric Diagnostic Manual, the DSM-5. So for the purpose of this part of the talk, I'm going to kind of use closely related terms interchangeably. So confusional state or delirium. So here, what it involves is a disturbance in a person's ability to pay attention and their awareness of their situation and what's going on around them. It often develops relatively quickly. It can develop over a short period of time. And one of the key things is this confusional state is a change from the person's baseline level of thinking abilities. And it may fluctuate during the course of a day. So it's not uncommon for one person who's at bedside in the morning to have an impression talking with the person that they may be relatively alert or clear-headed, but then later in the day, another person talking with them may observe more confusion than was present earlier in the day. So that's one of the features of delirium or confusional state, that it can fluctuate. And there's also some other cognitive process that's disrupted. For example, memory would commonly be disrupted. And delirium or confusional state is a term that's used with some restrictions. It doesn't refer to, say, a person who had a pre-existing, say, severe dementia or Alzheimer's, although those individuals can get worse during a hospital stay. But the delirium can be really superimposed or added to that baseline rather than, it's not exactly the same thing as their pre-existing memory problem. And secondly, it doesn't refer to if someone's in a coma over a longer period of time. That's not exactly the same type of thing as when a person is alert but confused. So there is evidence in delirium from medical evaluation that this change in a person's mental status is due to either their medical condition. It's also observed when people have intoxication with substance abuse or are going through withdrawal from substance abuse or side effects of medication. And some people with this confusional state are very hyperactive and agitated at times, and others may be very slow and less physically active than usual. And there can be some accompanying emotional changes as well. So in essence, in the hospital setting, in an ICU or in long-term acute care, the delirium state, the person may be drowsy or distractible, sometimes may have symptoms of hallucinations where they're misperceiving things, either visual hallucinations or thinking that they're hearing things that aren't actually present. And sometimes they develop beliefs that aren't based in reality or delusions. So that's just general background about the confusional state or delirium that can happen during the hospital. And what we had known previously is that when people are in an ICU or going through long-term acute care, that if there's this delirium state, it's associated with more difficulty of that person coming off of a mechanical ventilator and usually a longer period of time in the ICU or in the hospital. And we also have some research done in the past that has highlighted that when patients, particularly older patients, have this confusional state in the hospital, they may be at increased risk for longer term difficulties, at least during the first 6 to 12 months of cognitive problems or difficulty with physical functioning. So that's background about delirium. And a lot of that is based on the experience with people who are in the hospital or in an ICU with conditions like sepsis that affects multiple aspects of their medical status. And so among survivors of critical illness who needed ICU level of care, some research would suggest that 64% report having some difficulties in their thinking or depression or disability in their day-to-day living at 3 months after hospital discharge. And as much as 56% in one study reported those problems persisting up to a year after hospital discharge. So the reason I kind of mention this is that's sort of background that we're aware of about cognitive changes during hospitalization. And then when we now start working with patients who are recovering from COVID illness, the question that arises is this confusional state during the hospital stay, which may persist after the hospital, is it the same thing as this confusional state that we often see during critical illness, or is it different? Is there an incrementally increased risk for cognitive problems that's more specific to COVID-19? So one of the best studies for understanding this comparison is called the Brain ICU study that was published in 2013. And this was a multi-site study that examined individuals' long-term cognitive functioning after a period of critical illness. And this has also been referred to more recently, or in some context, as the post-intensive care syndrome. So it generally refers to longer-term thinking problems, physical problems, or emotional changes among people who survive a critical illness that is at the level that they need hospitalization at an intensive care unit level of care. But however, this is different than traumatic brain injury or stroke. It's more refers to intensive care that syndrome that is persisting for other reasons. So here's some information about this study that I think provides a relevant context for understanding the individuals who had hospitalization and ICU level care for COVID. So this is more general prior to COVID. The study was published in the New England Journal of Medicine and involved 821 patients whose average age was about 61 and were in the hospital for about 10 days. And individuals who had severe dementia or Alzheimer's were not included in this study, although about 6% had some type of mild cognitive problems or were thought to have had mild cognitive problems even before their hospitalization. So this is a good comparison sample of individuals who were very sick and at ICU level of care, and 74% of them developed this confusion or delirium during the hospital stay. And what the researchers did was they followed them after they left the hospital and rechecked their thinking abilities using a neuropsychological test called the Repeatable Battery for the Assessment of Neuropsychological Status, or the RBANS. And so they did this test at 3 months, and then they repeated it again at 12 months. So let me explain some of the results of this Brain ICU study. And on this graph, what we have on the left are the patient scores on this cognitive assessment. And on the right, we have different age groups of individuals. The first two refer to people who were age 49 or younger at 3 months, and then again at 12 months after they left the hospital. The middle group is patients who are between the ages of 50 and 64. And then the group to the right, patients who are between 3 months and 12 months who are over age 65 or older. And for this test, average scores are generally from the about 90 to 109. So that's the green band in the middle. That is essentially what we would expect for the sort of average range of thinking abilities. And you can see that this group as a whole of individuals across these age groups, when they're assessed, their thinking abilities are checked at 3 months after hospital discharge or at 12 months after hospital discharge. They're below the level that we would expect. So you can see that in the group who are 49 years of age or younger, there's a little bit of improvement between 3 months and 12 months, but still below average. And that holds true for the middle-aged 50 to 64-year-old group. And when we look at the group of individuals age 65 and older, we can see that they have not returned to the baseline level of their cognitive abilities. So here's a summary of what this brain ICU study tells us about the risks, at least for some individuals, when they have critical illness that requires an ICU level of care, what their thinking abilities are like after hospital discharge. So at 3 months, the cognitive functioning of 40% of the patients was about 1.5 standard deviations below the mean score for their age. So that's basically below the 15th percentile, which is comparable to the types of cognitive functionings of individuals who've had a moderate traumatic brain injury. And at 3 months, about 26% of them were below the 2nd percentile, which is really in the range of mild dementia. So this is kind of a concerning finding that even after patients who survive an ICU level of care for critical illness are often at risk of these lingering cognitive problems at 3 months. And then at 12 months, we find again, about 34% are below the 15th percentile and 24% very low at below the 2nd percentile. And here's a graph which just kind of presents this visually. So on the bottom, we have the number of days that the patient while in the ICU was in a state of delirium or confusion, ranging from 0 up to a little bit more than 10. And on the left are their scores on this sort of general measure of thinking abilities. And what the researchers found in the brain ICU study was that the longer period of confusion during the ICU care was associated with worse cognitive functioning at 3 and 12 months. So the longer that delirium goes, the higher the risk of these cognitive problems. So these authors had concluded that the delirium during a hospital stay may predispose patients to long-term cognitive problems, but the reason for that is not entirely clear. It may be due to inflammation, it may be due to death of nerve cells, it may be associated with some type of atrophy of the brain. It's really not clear. So this study is very provocative and draws our attention to the need to follow patients when they leave the hospital for an ICU level of care and to monitor and track their cognitive functioning, as well as take whatever steps can be made to manage as effectively as possible that confusional state when people are in the hospital. So that's the background about the kind of confusion that can occur during the hospital in general at an ICU level of care. And the next group of slides that I'll talk about is more specific about COVID-19. So here's some information about what is known at this point about delirium during COVID-19 illness. So in the left column, I've just summarized a 2020 study by Khan. These authors studied 268 consecutive hospital admissions between March and June, people who were admitted with COVID-19. And the assessment method they used is called the confusion assessment method. And this study tells us a little bit more about the base rate or the frequency of this confusion during a critical illness with COVID-19. And what they found was 29% had this delirium or confusional state without any coma during their hospital stay. 28% had the state of delirium and then lapsed into coma, and 23% were in a coma and then had the confusional state as they emerged from coma. So in this study, there were about 5 days was the average period of time of this delirious state. And what they found was that individuals who were in the hospital in the ICU who required mechanical ventilation were at increased odds of developing delirium over and above the effects of things like sedative medications that can also sometimes cause confusion. Now, the second study on the right was a much larger study, an international study from 69 intensive care units across 14 countries. And what they found was that there's a very high burden of acute brain dysfunction during ICU level of care in this global study. And there may be some differences across different regions, but they found that more than 80% of patients had a period of coma and more than half developed this delirium or confusion. And it lasted on average about 2 weeks. And the authors draw our attention to the possible implications for those that survive this of an acquired dementia, or in other words, the question that I began with is, can this COVID-19 cause an acquired brain injury, a significant change in a patient's longer-term cognitive state due to the illness, either directly or indirectly? What they also found was that among the things that may be modifiable or changeable during the course of hospitalization that predicted delirium was, one, the need for benzodiazepine infusions, which is often necessary during ICU level of care, but it is associated with an much higher increased risk of confusion and delirium. And on the other hand, family visitation was associated with a decrease in risk for delirium. So during this particular pandemic, with the restrictions on family visitation, it seems that that kind of increases the risk of confusion when individuals don't have access to that kind of orientation and familiarity to people close to them. Another study that tells us a little bit more about how COVID can cause neurological symptoms is done by Leota and colleagues. And they looked at the records on 509 consecutive patients who are about, on average, 58 years old. And they found that 26% of this group had COVID-19 at a severe level that required mechanical ventilation. And they defined neurological symptoms somewhat broadly. Some of these symptoms may or may not really be truly neurological, meaning brain or spinal cord related. But here's what they found in any case. So they identified neurological symptoms as being present at the onset of the illness in about 42%, neurological symptoms at the time of hospital admission in about 63%, and at any time during the course of the disease in about 82%. And as you can see on the screen, the percentage of different neurological symptoms ranged from 45% approximately to 11%. So myalgias or muscle aches and pains, headaches, encephalopathy, which is our interest in this presentation, essentially meaning a confusional state of diffuse cognitive problems or brain dysfunction in about 32%, dizziness in about 30%, and then difficulties with taste or smell in a substantial portion. The neurological symptoms that were less common during hospitalization with COVID-19 were stroke, movement disorders, very specific motor or sensory deficits, a gait ataxia, and seizures. So what these authors found was that patients who had any neurological symptoms during the course of their illness were actually surprisingly younger than those who had no neurological manifestations. And then the specific issue of the confusion or encephalopathy, there was significantly higher risk among the older patients with COVID-19. It's not surprising that they would be more at risk for this confusion. The patients who developed encephalopathy also got into the hospital more quickly. They had a shorter time from the onset of their symptoms to their hospitalization, were more likely to be male, and also have a higher incidence of other medical conditions, neurological conditions, cancer, stroke, kidney disease, diabetes, high lipids, heart failure, hypertension, or smoking. So these authors concluded that the cause of this encephalopathy or disturbance of brain functioning during COVID illness can't be determined with certainty, and there's probably multiple factors that contribute. So one possible contributing factor is that COVID is a multi-system disease, and there's an inflammatory process that can affect many parts of the body. Secondly, a blood clotting or a coagulopathy. Thirdly, a direct invasion of the virus into the brain, which is less common, but there have been reports about cases in which that happens. Endotheliitis, which is an inflammation of the lining of the blood vessels. And then additionally, possibly some post-infectious autoimmune reaction that can also contribute to cognitive problems. So these are the possible ways that the COVID illness can affect brain functioning. But one of the main points that I'd like to make is that those factors which may be at higher risk with COVID are also superimposed on the more common risk factors that are associated with cognitive problems occurring when people are critically ill and require an ICU level of care. So when we think back to the brain ICU study and the findings of how sedative medications can affect cognitive functioning, disrupted sleep-wake cycles, and finally, complications of infection. So what these researchers concluded was the increase in morbidity and mortality associated with encephalopathy with COVID is independent of the severity of respiratory illness, and in that respect may be similar to some of the previous research that was done prior to the emergence of COVID. And essentially, what we learned from studies like this is that there are risk factors for severe illness with COVID-19. So I'm sure many of you are aware of this. It's been very well sort of documented and communicated that conditions like obesity, diabetes, and hypertension are risk factors for severe COVID-19 illness among those that acquire COVID-19. And the main point I want to make here is those same risk factors, obesity, diabetes, and hypertension, if those things are not well controlled, they're risk factors for cognitive decline after COVID-19 illness. So this emphasizes the need for behavioral health care support after patients leave the hospital to ensure their attention to and compliance and access to care for diabetes and hypertension, so that to the extent that those factors can be modified, they have the best possible outcomes. So to summarize, for many ICU patients, this shorter term delirium or confusional state is at least partially reversible. It can improve before people leave the hospital. But some people are at risk of this longer term cognitive problems after an illness that requires ICU level of care. And there may be some unique factors to COVID-19 that add to the risk that exists already by virtue of the person having just a generally severe critical illness. So some of the things that need to be considered is sometimes that critical illness takes a long time for recovery, so that individuals' recovery may be prolonged, such as what we see in the post-intensive care syndrome. Secondly, and this is what we've noticed here in our outpatient work with individuals who have had hospital level of care for COVID-19, is that many report persisting shortness of breath and fatigue. And this is also reported elsewhere as well. So it's possible that this incompletely resolved pulmonary status may also be a risk factor for prolonged cognitive problems because of the extent to which the respiratory insufficiency may also affect brain functioning. And then finally, as I mentioned before, this risk for cognitive problems after COVID-19 illness is superimposed on other risk factors like diabetes and hypertension or obesity, or what is sometimes referred to as the metabolic syndrome. So the final thing I'd want to mention and bring your attention to is long COVID or long haul COVID, which you may have heard about. So the main focus of what we're trying to communicate with you about today is whether COVID-19 can cause brain injury, a different kind of a brain injury than say head trauma. In this case, it's brain injury due to an infectious disease or complications of a severe critical illness. So what I've been talking about with you so far is information about mental status among individuals who have severe COVID-19 that requires them to be in the hospital in an ICU level of care. But there's this other group of people who have had COVID-19 who did not require a hospital level of care, who are reporting persisting symptoms that range very widely in terms of the scope of the symptoms and may also occur in cycles or in different waves. And this has become known as long COVID. So the article on the left by Shah that I mentioned, Managing the Long-Term Effects of COVID-19, essentially those researchers highlight the most common symptoms, including fatigue and shortness of breath. And the idea here is that the likelihood of developing long-term effects of COVID-19, this long COVID, is not thought to be related to the severity of the acute infection. In other words, individuals who may initially have relatively milder symptoms of COVID-19, who later in the course are reporting many more symptoms than would be expected after a relatively mild episode of acute illness compared to individuals that require a hospital level of care. So the final thing I'll mention about it is a fascinating article that was recently published about how and why patients made this long COVID syndrome. So if you're interested in it, it's a nice kind of summary of a change in the evolution of a scientific understanding of an illness or a syndrome. Because typically, the knowledge about these syndromes emerges from the medical community. And in this case, it was more of a bottom-up, grassroots kind of effort among an international network of people who were experiencing symptoms who came together. And what emerged from that is the notion of long COVID. So the directionality, I think, is very interesting in terms of responding to COVID as healthcare providers and the need to be inclusive to pull them into that information into our approach to healthcare and to listen to what the patients are saying about these prolonged symptoms that have become known as long COVID. But the question remains for that syndrome, will this persist as a term as there are now efforts to make guidelines for diagnosis, or will it be found to be secondary to other things? It's too early to tell for that. So I'm going to now hand over to my colleague, Wendy D'Angelo. Thank you.
Hello, everyone. My name is Wendy D'Angelo, and I'm part of the leadership team at Hospital for Special Care. I've had the opportunity throughout my career to study the impact of health disparities on specific vulnerable populations. I'm very pleased to be able to join my colleagues, Dr. Hammond and Dr. Belliveau, in speaking with you today about health disparities and the social determinants of health have had an impact on the patients we've cared for over the last year who've been severely impacted by COVID-19, and how these issues impact the well-being of individuals with other types of brain injury. Hospital for Special Care plays a unique role in the healthcare system in Connecticut. We provide a level of care and a highly specialized clinical expertise that's not available in other settings. Our patients face medically complex and often catastrophic injuries, including complex strokes and traumatic brain injuries that cannot exhaust their own and their families' resources. Patients come from every community in our state and from all walks of life. For many, Hospital for Special Care may be the only qualified healthcare provider available to care for a particular patient or group of patients. That means we play a critical role in ensuring equitable access to high quality care for some of the most medically compromised patients. So assessing the outcomes of care is extremely important to us. We want to know that what we're doing works, and we want to know that what we're doing works for every patient in our care. Understanding that COVID-19 in Connecticut and across much of the country was having a disparate impact on communities of color and low-income communities we understood that if we were going to open a dedicated unit to care for severely impacted patients too compromised to safely return home following their stay in the ICU, we needed to understand not only who was admitted to our designated unit, but also that the care we provided was effective across racial, ethnic, gender, and other factors. What we found when we looked at our initial patient cohort was that individuals of color, especially Black and Latinx patients, were disproportionately represented as compared to the population of our state and disproportionately represented among Medicaid patients in the cohort. What we also saw was that a disproportionate number of patients of Black or Latinx racial or ethnic background had multiple pre-existing risk factors for severe illness, including diabetes, obesity, and hypertension, as compared to white patients in the cohort. We also saw that non-white Latinx patients were significantly younger than white patients in the cohort, and patients of color were likely to have poor health before they contracted COVID and were more likely to require intensive rehabilitation following ICU level care. We found that by discharge, however, our clinical teams had leveled the playing field for all patients as they progressed in recovery from COVID-19. We saw dramatic increases in patient mobility and strength, as well as in lung function. Critically, there was no difference in the rate of improvement by race, ethnicity, or gender. Victory, right? Health equity, right? Well, sort of. While we celebrated each patient discharge, and yes, there were socially distanced parades from the unit to the hospital entrance where families were reunited for the first time in weeks or even months, but we were also aware that our patients were returning to the same community, the same social determinants of health that may have contributed to their overall COVID risk, and would certainly have an impact on their continued recovery. So what happened next? Patients from suburban communities with personal transportation were more likely to return for follow-up care than patients, including patients of color, from urban communities with transportation barriers. Among those patients returning for outpatient care post-discharge, individuals of Black or Latinx racial or ethnic background reported less improvement in anger, fatigue, depression, and anxiety than their white peers. We know, and as Dr. Belliveau just mentioned, that this is a concern. Follow-up behavioral health support is important for patients when they leave an inpatient environment after a medical trauma. So that leaves us with concerns about the long-term recovery outcome of our patients. But it's not unique to COVID patients. All of these issues impact other patient populations, including patients who experience traumatic or other forms of brain injury. So I mentioned social determinants of health. These are the conditions in the environments where we live, learn, work, play, and worship that affect a wide range of health, functioning, and quality of life outcomes and risks. Economic stability. Are there jobs in my community? Vacant storefronts? Affordable childcare? Educational access and quality? Are there good schools in my community? After school and enrichment programs? Preschool? Healthcare access and quality. Do I have a primary care provider? Do I receive preventative screenings? Do I have the resources I need to manage chronic health conditions like diabetes? Neighborhood and built environment. Do I live in a food desert or a food swamp? I mean, that means is there a grocery store in my community, or do I rely on small convenience stores that don't really have a lot of fresh produce? Are there safe places to walk, run, play? Do I breathe fresh air or exhaust fumes? Is public transportation accessible to me to have a job or get to a healthcare appointment? Social community and context. Do I have support at home, at school, at work? Am I alone or isolated? Do I have peer connections that understand the challenges I face? Our individual answers to these questions comprise the social determinants of our own health and ultimately influence our health outcomes. These determinants also impact health disparities related to traumatic brain injury, according to the CDC. The rates of TBI differ distinctly between racial and ethnic groups, with a higher percentage of injuries occurring in certain populations. It's also likely that non-Hispanic, Black, and Hispanic patients are less likely to receive follow-up care post-TBI, and racial and ethnic minorities are more likely to have poor psychosocial, functional, and employment-related outcomes following a traumatic brain injury. At Hospital for Special Care, we see the impact of social determinants of health when patients living with brain injury in the community come back into care in our neurobehavioral program, generally because the supports that they rely on in the community have eroded over time. So how do we begin to build a path toward health equity for individuals with cognitive changes related to COVID, for individuals living with brain injury, while we are still very much living in a global pandemic? First, we mitigate the risk of dual impact by ensuring that we all take steps to protect individuals at risk of severe COVID infection by wearing masks, practicing social distancing, and frequent hand hygiene. Second, get vaccinated when it's your turn. Not surprisingly, in communities that have long histories of neglect or even mistreatment from the healthcare system, there may be a reluctance to trust. We are seeing vaccine hesitancy in many communities, including communities of color and other vulnerable patient populations. What can we do? We can engage partners in the communities most at risk to be ambassadors, to help people get their questions answered by trusted, reliable sources. If you are a member of a community that's at risk, become that partner. Help keep the conversation moving forward. COVID-19 brought a spotlight to health disparities in a way that has forced our national conversation to change. But it shouldn't take a global pandemic or the deaths of more than 500,000 Americans to get our attention. Let's think together beyond pandemic recovery to how we can take the lessons we've learned and change the narrative for patients who've had COVID, for patients living with brain injury, for patients living with a range of other complex health issues. Let's talk about how can I be part of the effort? How can you? I want to thank you for taking time to be with us today. I look forward to collaborating with Dr. Hammond, with Dr. Belliveau, and with all of you in the days ahead to advance health equity in all of the communities we serve.
All right, that was great.
Hi, welcome. My name is
Dr.
Dr. Alaina Hammond, rehabilitation
over.
psychologist at Hospital for Special Care. And I'll be starting off our discussion today on COVID. Is it related to brain injury? And from the ICU.
Okay. Sorry about that. It just looped around. So that was great. Thank you both very much. And thank you both for joining us.
Sure.
So a few people had to leave because they had a separate 2:00 class, but our class is all still here. And we really welcome you. That was really great and very informative and skillfully wove, post ICU and delirium into helping inform a very new, we know so little about COVID because it's been around for such a short time. So I really appreciated that. I don't know if either of you want to say anything or just open it straight to questions.
I'd like to just add something that we didn't mention, just to kind of perhaps also lead into some questions and discussion, but I did want to mention the weathering hypothesis. I think we had forwarded an article about that, and just to pick up on what the previous speaker, Wendy, was talking about in terms of healthcare disparities and social determinants of health. So I would just mention, as summarized in the article that some of you have seen, this hypothesis for why there may be some racial and socioeconomic disparities in health outcomes So there's this hypothesis that came out of the literature on originally from studies of infant mortality or infant health outcomes, that they found differences between Black versus white mothers and the infant's health status, and also an interaction with age as well as socioeconomic factors. And there's been research to try to understand what may be some of the risk factors or determinants of those differences in infant health, and then by extension, the risks for other chronic health conditions. So the hypothesis really talks about the cumulative or chronic effects of disadvantaged socioeconomic status or access to healthcare barriers, and that the hypothesis is that cumulatively that can contribute to an acceleration or early onset of later in life multiple health conditions, whether that's conditions like diabetes or hypertension or other chronic cardiovascular diseases. So the authors talk about something referred to as allostatic load, which is essentially how much stress can the person sort of withstand and try to cope with and return to homeostasis. But then if there's another stressor on top of that, it becomes stressed all that much more. So that's what that article talks about, really as a sort of conjecture or hypothesis that has been extended. So our thought on that is that perhaps what we see with the COVID-19 is that sort of multiple risk factors cumulatively adding up to unfortunately create risk for cognitive issues or other secondary complications of the COVID. So that's just put out there for discussion, perhaps.
Perfect. That's great. Yeah, we did read that article. It was very informative. Thank you for that. And I think really topical, and again, kind of ties in, you know, our rising awareness of the effect of race and racism on health with questions around COVID. So do you want to take questions now?
Yeah.
Sure.
Okay. So does anybody have any questions?
We answered all your questions.
None? I know my students prepared questions.
That's okay. Sometimes it's oh, there's one.
Hi, so I just wanted to ask a question based on what you were just talking about in terms of like the differences in COVID recovery based on race. Is there anything that your hospital is doing in response to these findings, and just in general what people can do in response to like differences?
I mean, I can tell you what I'm doing in response to all of this. I mean, I have been trying to follow up with every COVID patient that we have here. So anytime somebody comes in with a COVID diagnosis, I automatically am consulted throughout the entire hospital. And so I'm trying to also follow up with these individuals. And I think I spoke about this, and that follow-up is challenging. But ultimately, we have a lot more work to do. I know that Wendy is also broadening the scope as far as how we're trying to get people who, after their discharge, to keep them in the system, because that's the hardest part, is that once everyone's here as an inpatient, people get great care, but it's back home that we're finding these differences, and it's harder to get people access to care. So it's about growing systems, it's about getting better outreach, and it's about, as a psychologist, taking on more responsibility and reaching out to your clients, your patients, and checking in on them. Did you make your appointment? And if not, you know, what was the barrier? So it's taking an extra step. And sometimes that means, you know, being a little uncomfortable and maybe trying to talk to family members, or if it's a household that speaks another language, you know, trying to figure out alternative ways of communication. But that flexibility is key.
I can add to what Dr. Hammond mentioned also, as I think some of the slides that Wendy showed kind of referred to is the sample that we presented was earlier in the pandemic. And when we looked at things like insurance coverage for the cohort of people that we saw earlier, and where they lived, we kind of created an overlay of the map of Connecticut, and we could see that our patients came from a broad area across the state. So those that happen to have lived close to where we're located in New Britain, it's a little easier to, in terms of transportation access, to have them come into our outpatient clinic. But when they're further away, there's transportation issues, just distance and time, as well as access to transportation. So I know that one of the things that Dr. Hammond did, I don't know if she had mentioned it, but just like we're doing now with the Zoom, one sort of adaptation is telehealth. So if people can't come into the clinic physically, Dr. Hammond's been reaching out to them through telehealth links. It's a little harder to do cognitive testing follow-up that way, but we did some of that on an inpatient basis as well. So those are some of our efforts up to this point. In addition to just tracking, we don't always track when people come into the hospital. We don't necessarily create a group of people with a certain diagnosis and follow them and monitor them as outpatient. And we've tried to do that more with this group to see if they have the kind of follow-up that they need.
And yes, I would second that cognitive evaluation via telehealth is quite a challenge. And have you guys talked about that at all?
I actually have a student doing her senior thesis on it. I might send you the link to the survey. She's surveying people with brain injury to see what aspects of telehealth they like, what don't they like, what works, what doesn't work. We're trying to do all of our research studies via Zoom, and it is such a challenge. but I do think there's positives, right, that hopefully we can hold on to. So for some folks, right, transportation is an issue, and not just access to transportation, but with cognitive deficits, navigating, figuring out where you are, with social anxiety issues, trying to find a new place, trying to, see a new provider. And all of that can be alleviated with telehealth. So I think we just need to figure out the ways. And I think to the point that Juliana asked, she presented really well a lot of the social determinants of health. And I think we as a society need to figure out, so transportation's kind of the low hanging fruit, like how do we get people in? But then the other side, do we provide childcare on site? Do we provide, do we go out into the community and provide care at grocery stores and barbershops? I mean, so there's huge barriers that we as a society could decide that we wanted to work on or not, but I think it's a long range issue.
Well, interestingly, there's also a prospective memory aspect to the telehealth.
Well,
in terms of remembering that from a provider perspective, we have people that make reminder calls, in advance, but sometimes we'll log on and the person won't be there. So then we call and try to reach them. So that's part of it too.
That's true in person too, right? So
Yes.
I'm doing 2 studies right now on 2 different patient populations, seeing if coming back to outpatient visits for like PT, OT, speech are correlated with prospective memory performance. Because I think a lot of times people get labeled non-compliant, again, like there's all kinds of, implicit biases. So certain groups of people get labeled non-compliant when they forget, when they're really just forgetting, or at least a piece of it is just that they're forgetting.
Especially with this group of individuals who have been through inpatient treatment for COVID. When we see them as outpatients, there is a mix or a variability in their overall status when they come back to the outpatient clinic. But there are many that still have that shortness of breath and fatigue. They just don't really look well. And I can only imagine like the sort of initiative it takes to kind of mobilize oneself when you're feeling that poorly to get all the way into the outpatient clinic. So that's, I think, just the general being sort of worn out by the illness is part of it too.
Oh yeah, that's really huge.
And I can speak like right now, we still have several patients who are here for going on like 6 or 7 months. So there's still people who haven't left the hospitals type setting that may or may not make it home. And I think that that's really important piece, that not everybody's home after they went to acute care, right? So a lot of people are in this transitional phase where their breathing may or may not be coming back. We're not really sure if they can be placed at a subacute facility. So it's a long recovery. It's a very long recovery.
Wow, that's a great reminder. I want to let Elena ask her question, and then I want to hear what y'all think about long haul COVID. Like, what do you have a sense of what you think is going on? But Elena, do you have a question?
Yeah, I do. Thank you. It's a very similar question, I think, that Professor Raskin might be pointing to. But you obviously established that there's quite a disproportionate difference between racial and ethnic representation in the ICU when treating for COVID, and also a difference when they go home in terms of fatigue and anxiety and depression continuing. And I was just wondering if you are aware of any studies or yourselves are aware of any differences in the race or ethnic distribution between those patients who present with severe acute COVID versus those who have the more long-term COVID that you were talking about? And if so, if this is mainly due again to economic status and differences in healthcare, or if there might be something else going on.
So, Dr. Belliveau, do you want to take this one, or do you want me to?
I was just going to mention, I think, if I remember our earlier group of people that came in, the younger group were more likely to be non-white. That was one of the main findings. Do you want to add to that, Dr. Hammond?
So
the younger cohort, and I think more Latinx representation in the younger group.
yes, absolutely. Yeah. But at the same time, I would say that, while they were here, all of their scores again fell within a very normal range. So the data that we have for follow-up is really that immediate once they got home and that adjustment period. So whether or not they're at that long haul phase at this point, that I can't speak to. But, this acute care phase, I can say that, there were definitely differences, but, I don't know of anything off of the long haulers yet. And I'm curious about the data with respect to long haulers because, like Dr. Belliveau was saying, we don't have a great diagnosis for that yet. We don't have a definitive representation of the symptoms and that everybody's agreed upon. And so I would be cautious about interpreting any studies at this point until the community really does agree upon an operational definition for it.
Yeah, I'd be interested in what the students, what you think about long COVID or long haul COVID, and just kind of generally defined as initially maybe not that severe of an illness at the time of onset, but then this lingering, ongoing constellation of problems. What are your thoughts on that? Anybody want to make any comments about that? No takers?
What about thoughts about related to, so what are some psychological issues when you have trouble breathing? Let's keep it simple. What do you think people are experiencing when you have trouble breathing from an emotional stance?
Probably a lot of anxiety.
Yeah, a lot of stress.
Right. So if you're having a lot of anxiety, what does that do to awareness of bodily sensations?
You're not really focused on your bodily sensations when you're anxious, I feel like.
Maybe. So what happens is if I start breathing, right? If I start going, what's going to happen?
I think you're more aware of it and you're trying to control your breathing and
There
you're
you
focusing
go.
on it nonstop.
Right. So there's a hyper awareness of bodily sensations and increased anxiety. And so what happens when that occurs is that people often then think, oh my gosh, there's something really wrong with me. And then they become overly focused on that. And what happens up here? They start forgetting or not paying attention to things because their anxiety gets in the way. So it is really important to, when you look at COVID, you also assess anxiety.
And I think I'd like to add to that, just the phrase brain fog, we've heard before, and now the phrase is kind of introduced to refer to the experience of some people with these sort of long, prolonged symptoms that are being attributed to COVID. There very well may be something there with a direct effect of COVID on these symptoms, particularly physical symptoms like respiratory symptoms or fatigue. But I think a lot more would need to be done for me to kind of have a confident sense that the cognitive issues are really directly COVID related rather than maybe secondary issues. So, and the reason I mention that is we've heard terms like brain fog. It comes up with other medical conditions, some of which are not really well defined. So among people with fibromyalgia who report difficulties with concentration or cognitive efficiency, we sometimes have people come in and say, I have fibrofog or fibromyalgia brain fog. And we see it also with concussion. So early in recovery from concussion, there's often direct neurological effects of concussion on thinking. But then as time goes on, typically those cognitive problems improve. But many people who years after a single mild concussion will describe their symptoms as sort of brain fog, which they attribute to concussion. So although for some people that may be the case, just the label or the description as brain fog, it's to me a little bit too meteorological in nature to really know exactly what's meant by that. So that's what I would look for, is it to kind of move out of a general description of what I translate as cognitive inefficiency. The thinking is just not as efficient as it was before. And then we can kind of get to the task of sorting out how much of it may be directly related to COVID and how much of that may be related to other things.
I always think about all those mommy brain studies in the same sort of context.
Mm-hmm.
So students, you're welcome to ask them just about working with people with COVID and what that's been like, and also just kind of trajectory. Oh wait, Corinna says, my question was already answered. They're all texting me individually that you've already answered their question. My question was already answered, but out of curiosity, what path did you take to get into this area of research, and how are you promoting the research you're doing? So I know you're clinicians more than,
Yeah. So Dr. Beller, do you want to go first? Or you?
No,
Who,
go right
who's
ahead.
that?
In terms of how we arrived at this, I think you can kind of describe that, how that
Sure.
transpired.
So I was sitting here at my desk and I felt a lot of anxiety because I realized that there's a whole host of people coming here that I don't know anything about. So I said, what can we do? And so Dr. Belliveau and I put our heads together and we said, okay, we need to think like researchers, like clinicians, and we need to get some data because we don't know what we're going to experience. So this was like right before, so things were kind of hitting New York and we hadn't first gotten our first patient here yet. And so we both looked at each other like, hey, we're going to get COVID patients here. What are we going to do? And so that's when we decided that yeah, we needed data. And so it wasn't necessarily built out of the desire to do a research study, to necessarily do a talk or anything like that. It was truly based out of clinical need at the time. And because we really didn't know what we were going to see. And so that's what we did. And so in the beginning, I did a lot of telehealth because at that time we weren't really sure, the whole mask thing was up in the air and there was a lot of unknowns. And then as I grew more comfortable, I was able to fully gown up. I was fit tested, and then I was going up there and being able to assess patients in person. And so I can talk to you about what that's like and learning how to don and doff PPE and getting used to that whole experience, and trying to give tests with PPE is not easy. There's a lot of barriers. There's a lot of things you have to think of that you wouldn't have normally considered. So that's where it really born out of. But as far as, where the research is going, I think that's to be determined. I think we really need to sort of think about, well, what's the next step? What's needed at this point? Because at this stage, most of the patients I see with COVID, very few have PTSD like reactions or related to delirium or anything like that. Most of them do not remember their time at acute care due to the heavy sedation that was used. So, and we've talked to some of the pulmonologists here who have said that the amount of sedation that was used was increased due to the factors at acute care. So most of the COVID patients that I have come in contact with do not recall any of their acute care experience. They're kind of more or less awakening at the very end of it and starting to recall and make new memories of their time here. So that would be where my position comes in. But Dr. Belliveau, do you want to take over that?
No, just what I would say also is to please put the data that we presented in the context that this is not a large number of people that we had here compared to subsequent studies. So we were looking at this early on in the pandemic because we've always on our close observation unit where patients are admitted after they leave ICU and come here, we routinely do cognitive assessments when they're needed or psychological consultations. So that part wasn't different. It was just a different illness of the patients coming in. But it's a relatively small number. And so we just wanted to get a sense of what's happening locally in our little area here. But the other thing to keep in mind is that the treatment for COVID did evolve and change over time. So I would, in terms of promoting this research, we're not particularly promoting our sort of look at our small group of people because there's much larger studies that have since been done. And it's a mix of people. The larger studies sometimes include a mix of people who were treated earlier in the pandemic and people who were treated later. And the treatment methods have changed and evolved too. So it is hard to sort out. There's also variants, different, as you know, different strains or different variants of the COVID. So it's hard when you get, hundreds of patients into one study to sort through some of that, but it can be done statistically. But our numbers of our group is really too small to do much of that.
Great, we appreciate that you did this. Students, do you want to run your videos just for a second? It's all these little black boxes here. If you can, if you can't, but if you can, it's nice to be able to run your video so people can see you. Anybody else have a question about trajectory or their research or just working with people who have COVID? Look at, they live.
Hi, guys.
Sierra?
It's not really a question, I guess. I just kind of want to hear your thoughts on when you think everything will go back to normal, so to speak.
Oh, I wish I knew. Wouldn't that be nice? I can say that things are turning for the better. I do. I feel much more comfortable with our systems here. I'll be honest with you, I was scared of COVID just like everybody else in the beginning. And now I feel much more comfortable with the fact that most of us have been vaccinated. I've been vaccinated. If you're not vaccinated, I encourage people to get vaccinated. It's a good thing. And that from seeing the effects of COVID firsthand, it's not something we want to mess around with, but at the same time, I really do see that our treatment for it has dramatically improved. And I actually have a lot of faith in our healthcare system that we're going to get through this okay. So I do see a light at the end of the tunnel.
Yeah, I would say I'm going to have to bow out of any, as Dr. Hammond did. I'm not in any position to really answer that question with any sense of authority. And I would, encourage you to continue to follow what you hear from the CDC, from the NIH, and those sort of healthcare leaders. And also, as Dr. Hammond saying, got to promote those vaccines. It's important to get vaccinated across all age groups. And I think for many of you, you're in the age group now where the vaccines are available. So I hope you take that into consideration and don't be giving up the masks too soon. Let's just stay the course, and hopefully things will turn better. So other questions?
Rachel.
Yeah, hi. I was wondering if, since sort of the, let's see, the number of like the PICS diagnoses that you talked about of sort of after someone leaves the hospital from COVID, if there's sort of been an increase in those diagnoses. I know you said it's very difficult to diagnose like right off the bat, but if there is, or just in your opinion, like there should be, if you think that's more attributed to sort of what happens to the body physiologically with COVID, or is it more sort of about the lack of supportive or protective factors, such as like we're all in quarantine and so you don't have your family or your friends around you, sort of what you think you could attribute any like cognitive results from it to?
I think it's definitely multifactorial, like you're saying. One, we know that isolation itself is a form of torture, right? It causes all sorts of unwanted side effects that I think to some degree, probably everybody has experienced during this time period. So it's not, we can't just parse it out related to that. But as far as, the emotional distress, is it related to the lack of ability to, get your daily needs met? It could be. We don't know what it's all related to yet. I think it's also dependent upon the severity of the individual's COVID symptoms, right? Some people might just, they might be able to maneuver pretty well. They just have a little bit of shortness of breath. Other people, they're on oxygen for the rest of their lives. And some people are embarrassed by that. And what's that like to have an oxygen tank, and maybe they don't want to go out and be seen, or maybe they're too worried to leave their home because they're scared they're going to get sick again, right? Because after a while, the immunity wears off. And so there's a whole host of factors that I don't have answers to, but you bring up a good question.
Yeah, I think another thing is the impact of the pandemic, not only we're focusing on the one person that comes into the ICU, and we're thinking about how does that person fare longitudinally over time as an outpatient and later. But it's not only that person's illness. So we have people who come in and unfortunately they may have other family members who've also had COVID or perhaps not survived COVID illness. So when we look at things like the depression and the impact of the illness, it's not only the one person, it's how it affects that person in their either family system or community and other people that may be similarly affected.
A really good point. Often there's a lot of guilt in the family system because, I'll see grandma or grandpa or aunt or uncle and, or whoever, somebody gave it to somebody else, right? And so there's a lot of families grieving and a lot of family issues, dynamics related to that.
Right. That's a whole nother layer, isn't it?
Mm-hmm. Yeah. And I would expect to see that in the community as we move forward. More and more families probably coming to therapy at some point, or at least talking about what it was like to have so-and-so in their family come down with COVID after a visit with X, Y, or Z.
All right.
That's like.
Any other questions for them? All right. Well, I so appreciate you both coming in, and this was great. I really enjoyed it. Thank you very, very, very much.
I think there's a,
Oh,
this is
Well,
goodbye.
those are waves.
They're clapping.
Sorry.
They're
I'm,
applause. It's
Suddenly
a-
all the questions.
okay, I get it. I'm old. Sorry.
yeah, they're applauding you.
Okay, thank you.
Thanks, guys.
All
Have a good
right.
one.
Bye-bye.
See you. Bye.